Today we'll be going through Chapter 5, Settings for Psychiatric Care. We look at other settings for obtaining treatment. Entry into the healthcare system for psychiatric problems can be sometimes a mystery. And really, a lot of this has to do with stigmas that we've talked about previously, the way people look at mental health in general, health disparities. In general, are these differences that occur because of either gender, race, ethnicity, education, income, disabilities such as physical or mental, and then living in those rural locations, or sexual orientation. So we look at both implicit and explicit attitudes of how healthcare providers shape the interactions with their patients, guide expectations, and these all affect the way that these clinical outcomes occur. We also look at treatment for physical disorders and treatment of mental disorders. These mental disorders can be stigmatizing, and there's negative attitudes towards people that are mentally ill that often has harmful effects on both the individual and their family, and it results in things like social isolation, reduced opportunities for care. Having that psychiatric illness is often hidden because of some sort of embarrassment or concern over the stigma, the shame, or perceptions of being flawed as that person with that disability. So if you wake up one day and you have pain in your throat or a sore throat and a cough and you feel bad and you call your doc and they bring you in and they do a throat culture and they order antibiotics and you don't feel better in a couple of days, and then they might refer you to a specialist or run some more tests on you. That's when you have a physical disorder. However, when you have a psychiatric disorder, it becomes much more challenging in being able to access or navigate that system. And one reason is because we really don't have a standard frame of reference for the treatment of psychiatric problems. That can be for a couple of reasons. Someone may hide the fact that someone has psychiatric disorders, or they might be ashamed or embarrassed. So you may know things like that your grandmom or your mom had some sort of cardiac history or cardiac disease, but you may not know that they had a nervous breakdown or that they had some other psychosis and that they were treated by a psychiatrist. A lot of those extreme disorders that have those psychiatric components, such as schizophrenia or major depressive disorder, can impede or interfere with motivation of the client to seek care because of feelings that the actual disorder causes. Sometimes those psychiatric symptoms are confused with other conditions, such as anxiety disorders, often accompanied by somatic symptoms like that racing heartbeat or sweaty palms, could be misconstrued as some sort of cardiac problem. The psychiatric illness is largely based on symptoms and not on objective measurements such as EKGs or blood counts, so sometimes ruling out other physical illnesses is important. However, it also can delay treatment for these clients. Another complication in treating the mental illness itself is the unique nature of the system of care. The care is rooted in public as well as private sectors, and this chapter will talk about the different areas where we provide mental health care and the different MILUs, or the different mental health facilities. Treatment is presented in the order of acuteness, beginning with those in the least restrictive environments and a setting that provides necessary care while still allowing great freedom. It also will talk about how mental health is funded and about the different challenges in securing adequate funding. So mental health care started back around the time of the Civil War, where these asylums were created, and it was supposed to create an environment about recovery. It was supposed to be a positive or optimistic sort of environment. And back then, people had a special responsibility to care for these clients who were then known as the insane. So insane meaning not healthy. So there really weren't many effective treatments at that time. And in the early 50s, the only two real options for psychiatric care were either a private office or a mental hospital. At that time, there were about 500,000 patients in state hospitals. Many of them had disabling conditions, and they had become institutionalized in these asylums. As Medicare and Medicaid were created in the 1960s, the number of people in the psychiatric hospitals began to decrease. Medicaid had a really potent effect on it because it paid for short-term hospitalizations in medical centers and long-term care in nursing homes, but it didn't cover most patients that were admitted to a psychiatric hospital. So those incentives stimulated the development of general hospital psychiatric units, and it led states to transfer geriatric patients from these state-paid psychiatric hospitals to Medicaid reimbursed nursing facilities. And then in 1999, the Olmstead decision to state that institutionalizing people in psychiatric hospitals was considered unjustified isolation, the opinion of the court that mental health was a disability and institutionalization was a violation of the American Disabilities Act. So it made this law that stated that all people with disabilities have a right to live into the community. So those forces led to the gradual and incomplete creation of state and county community care systems, and they serve to complement or replace the functions of those state hospitals. The number of state psychiatric hospitals continues to be cut and continues to be reduced. In 2015, there were only 188 state psychiatric facilities left. So that Olmstead decision, okay, made that decree stating that it was unjustified isolation by keeping these people in psychiatric hospitals. They developed these community care systems that replaced the state hospitals, and that number of state psychiatric hospitals continues to be cut. Social stigma related to mental illness refers to which of the following statements? Mental illness is a disease process. Mental illness is inherited. Mental illness is a complex problem. Mental illness is due to wrong thinking. The correct answer here was D. Mental illness is due to wrong thinking. Having a psychiatric illness is often stigmatized as being flawed in some way rather than being acknowledged as an illness. So they think about these people as being like damaged goods or flawed. Compare and contrast inpatient and outpatient treatment environments in which psychiatric care is provided. So inpatient 24-hour nursing care, this is the most intensive. These facilities provide 24-hour nursing care in a safe, structured setting. The setting is essential to caring for those in need of protection from things like suicide ideation, aggressive impulses, medication adjustments, and monitoring, crisis stabilization, substance use detoxification, and behavior modification. Referrals for inpatient treatment may come from the primary physician or mental health provider or another hospital, emergency facility, or nursing home. Admissions are made under the services of the psychiatrist, although a primary care physician may also have admitting privileges. Clients may be admitted voluntarily or involuntarily, so units may be locked or unlocked. Locked units would provide privacy and prevent elopement or leaving before discharged, also often referred to as AWOL, away without leave. They may also be psychiatric intensive care units within the psychiatric unit to provide better monitoring of those at an increased risk for danger to self or others. The therapeutic milieu itself is essential to successful inpatient treatment, and the milieu refers first to the environment in which holistic treatment occurs and includes all members of the treatment team in a positive physical setting with interactions among those hospitalized and activities that promote recovery. Crisis intervention is provided in emergency rooms, general hospitals, or in community-based crisis intervention centers. Crisis care may be initiated by the individual, friends, family, healthcare providers, or law enforcement. Sometimes clients are involuntarily committed. Psychiatric emergencies can include suicidal or homicidal ideation, acute psychosis, or some behavioral response to a drug. The stay-in facilities tend to be short, usually less than 24 hours. At that point, the client may be discharged home, referred for inpatient care, or transferred to another facility. Residential treatment programs are structured short or long-term living environments where the client is provided with different levels of supervision and support. Psychoeducation is provided for symptom management and medications, and vocational training or training for activities of daily living may also be part of the program. Residents learn how to access community resources as an alternative to hospitalization and are encouraged to achieve maximum independence. State acute care systems. Today's state-operated psychiatric hospitals are an extension of the old system. The quality of care has improved dramatically, however. The role of state hospitals is to serve the most seriously ill clients. This role can vary widely depending on the available levels of community care and on payments made by state Medicaid programs. In some states, state hospitals primarily provide intermediate treatment for a client unable to be stabilized in a short-term general hospital unit and long-term care for individuals judged too ill for community care. In other states, the emphasis on acute care is reflective of gaps in the private sector, especially for the uninsured or those that have exhausted their insurance benefits. In most states, the state hospital provides forensic care or court-related care and monitoring as part of the function for those found not guilty by reason of insanity. State or county systems can also advise the courts as to the defendant's sanity that may be judged to have been so ill when they committed the criminal act that they cannot be held responsible but require treatment instead. One tragic example is Andrea Yates, the Texas woman in 2001 who drowned her 5 children under the delusional belief that she was saving them from their own sinfulness. She was found not guilty by reason of insanity and committed to the Texas State Psychiatric Facility. General hospital psychiatric units and private psychiatric hospital acute care units tend to be housed on floors of a general hospital. Private psychiatric hospitals are usually freestanding facilities. The dramatic growth of acute care psychiatric hospitals and units is the result of a shift away from institutionalized state hospitals. Since that time, reduced reimbursement, increased managed care, and enhanced outpatient options, as well as expanded availability of outpatient and partial hospitalization programs, have resulted in the decline of these types of facilities. Primary care providers are often the first choice for people when they're ill, but how about when they think they have a psychiatric problem? Imagine you're feeling depressed, you're miserable, you're not able to carry out your activities. You recall that a friend who was depressed saw a psychiatrist, but that seems drastic. You don't feel that bad. Perhaps you're coming down with something. After all, you've been tired and not eating well. So you decide to visit your primary care physician. Okay, and that may be a doctor, an advanced practice nurse, or a PA. It's not an unusual choice. Seeking help for psychiatric problems from a PCP rather than a mental health specialist is common and similar to seeking help for other medical disorders. Most people treated for psychiatric disorders will not go beyond this level of care and may feel more comfortable being treated in a familiar setting. Disadvantages to being treated by the PCP include time constraints with the 15-minute appointment, usually inadequate for mental and physical assessment. Because they have limited training in psychiatry, they lack expertise in diagnosis and treatment of psychiatric disorders. They may be the only source for people using or receiving mental health services. Sometimes primary care physicians can refer people to someone with a specialty in mental health. Patient-centered medical homes receive strong support from the Affordable Care Act of 2010, and they were developed in response to fragmented care, resulting in some services never being delivered while others were being frequently duplicated. The focus of care is patient-centered, and it provides access to physical health, behavioral health, supported community, and social services. The services range from preventative care to acute medical problems to chronic conditions to end-of-life decisions. These homes have 5 key characteristics, these patient-centered medical homes. They have comprehensive care, so they provide all levels, preventative, acute, and chronic, regardless of whether they're mental or physical. They provide patient-centered care. The care is relationship-based and focused on the patient, the family, and takes into account the unique needs of each person. The client is a core member of the team that manages and organizes the care. They provide coordinated care, so care is coordinated with the broader health system such as the hospital, specialty care, and home health. They provide accessible services, so the client doesn't have to wait until Monday through Friday to get care that they need. In addition, extended hours of services. These homes provide email and phone support. They provide quality and safety, so evidence-based care is provided with continuous feedback loop of evaluation, quality improvement, and then sharing data publicly is an essential part of the commitment to quality and safety in the primary care medical home. These facilities keep excellent email reminders and record keeping. They are considered essential to that process. Community mental health centers were developed after JFK enacted the Community Mental Health Centers Act in 1963. And so he signed a policy about community care as opposed to institutionalization. Only about 700 of the anticipated 2,800 centers were funded. The legislation marked a change in direction, though, and led to state laws and budgets that help favor community care. These centers are regulated through the state and mental health departments, and they're funded by the state. In some areas, they may also receive local funding because of the limited government funding. Financial support services are sometimes restricted to those whose income and medical expenses make them eligible. So usually they're based on a sliding scale fee on the income and ability to pay. These community-based facilities provide comprehensive services to prevent and treat mental illness. Services include assessment, diagnosis, individual and group counseling, case management, medication management, education, rehab, and vocational or employment services, and some provide a variety of other services across the lifespan. Some are population specific, such as adult or geriatric or children. Because people with serious mental illnesses are often isolated, impoverished, or regressed, they can benefit from something called psychiatric rehabilitation services. And these are provided through those community mental health systems or other organizations. The psychiatric rehab is a social model emphasizing and supporting recovery and integration into society rather than accepting a model of dysfunction. So it helps develop social skills, access to resources, acquisition of certain optimal social working, living, and learning environments. Psychiatric home care can be provided by any mental health professional. Nurses who have inpatient experience are able to provide biologically based and psychotherapeutic care and can usually take the lead. The care may be coordinated by the community mental health system or through other agencies, such as some visiting nurse organization. Home care can reduce the need for costly and disruptive hospitalizations and offer a more comfortable setting and safer alternatives to clinical settings. To qualify for reimbursement, the client must have a psychiatric diagnosis, be under the care of a primary care physician, and be homebound. The homebound designation is given where patients cannot safely leave a home or if leaving the home causes some sort of undue stress. So if the nature of the illness results in the refusal to leave the home or if they can't leave the home unassisted. Usually one major insurer, Medicare, does allow the covered person to leave home once a week for religious services or for hair care. Intensive outpatient programs and partial hospitalization programs. These work as intermediate steps between the inpatient and outpatient care. The primary difference between the two is the amount of time that the client spends in them. Both groups operate Monday through Friday, but the intensive outpatient program is usually a half day, whereas the partial hospitalization is longer, about 6 hours, because they're partially hospitalized. The programs provide structural activities with nursing and medical supervision, intervention, and treatment, and they're usually located within a general hospital, psychiatric hospital, or part of one of those community mental health systems. Multidisciplinary team facilitates group therapy, individual therapy, and other therapies, whether it be art or occupational, and pharmacological management. Coping strategies are learned during the program that can be applied and used practically in the outside world and explored and discussed later. And then clients that are admitted to these IOPs or PHPs are usually closely monitored for admission or readmission to that inpatient care setting. Different mental health professionals play a different role in the community. If you are the mental health nurse and you work in the outpatient setting, you'll be providing nursing care for clients with psychiatric disorders, substance use disorders, those with intellectual disabilities, along with their families and the people that care for them. You'll also work to develop an intimate plan of care with multidisciplinary treatment teams, and you may or may not have to be certified depending on state law or facility requirements. As the community mental health nurse, you have to be knowledgeable about community resources such as shelters for abused women, food banks, agencies that provide employment services for those that have mental illnesses. You'll also be responsible for assessing the patient's living environment, the patient themselves, providing teaching. You'll look at the community as a patient themselves. You'll provide community supports, and you'll supervise unlicensed staff that works in the community. You'll also promote community interventions, such as things like conducting stress reduction classes or facilitating grief support groups. The advanced practice nurse is a valuable outpatient care provider. They are prepared at the master's level or doctorate level, and clinical nurse specialists will help provide assessment, diagnosis, and treatment in the outpatient treatment setting. Many APNs work in this setting, and they far outnumber the medically prepared colleagues or psychiatrists. These APNs are instrumental in providing preventive care to individuals in the community, and the focus of their care is teaching patients how to pay attention to their symptoms, to seek help when necessary, and to be mindful of their overall health status. Mental health workers or psychiatric aides or technicians are non-professional staff that may be state certified. They have extensive contact with clients, assisting with hygiene, meals, and participating in activities. Communication is important, as information with the patient's condition should be shared back and forth with the professional staff as needed. Occupational therapists, These therapists are going to help with assisting the individuals in regaining independent living skills, activities of daily living, and certain roles. Recreational therapists help with behavior as far as recreational activities to improve emotional, physical, cognitive, and social well-being. The PA also may help with, seeing the patient when the doctor's not available and relaying certain information back to the physician. The psychiatrist. This is a state licensed medical doctor with at least 4 years of additional training in diagnosing and treating psychiatric disorders. And then the psychologist is a licensed individual by the state, and they hold a doctoral in clinical education, counseling, and research psychology. Their expertise lies in evaluation, psychological testing, psychotherapy, and counseling. And then some psychologists may be able to prescribe based on what their experience or what the state laws are. Which of the following most correctly defines a psychiatrist? A medical physician, a psychologist, a mental health counselor, or a psychiatric practitioner? And the answer was a medical physician. Psychiatrists are state licensed medical doctors who have at least 4 years of additional training in diagnosing and treating psychiatric disorders. Medication prescribing and monitoring is a dominant treatment method used by the psychiatrist. So for treatment, mental health, there is consideration taken for special populations or specific groups of people. This would include pediatrics, geriatrics, forensics, veterans, people with alcohol and drug disuse, and self-help options. So for pediatrics, for kids that have mental illnesses, it's treated much in the same manner as adults, but it's done so in a pediatric population or setting apart from adults. Inpatient care is needed if the child's symptoms are severe, and then parental or guardian would be included in the care plan, as well as Department of Children and Families in involvement, and this is to ensure that the plan of care is met, that everyone understands how the illness works, what the treatment would be, and what the family's role is in providing support for that child. The child, even if hospitalized, may be able to attend school for several hours a day. With the geriatric psychiatric care, the older adult patient is treated and consideration is placed on the effects of aging and how that would affect those psychiatric symptoms. We look at physical illness, loss of independence, as these can be strong precipitants in development of depression and anxiety. Dementia is also a common problem that's addressed when we look at geriatric psychiatry. Treatment is aimed at careful evaluation of the interaction of the mind and the body and provision of care that helps to optimize strength, promotes independence, and focuses on safety of that geriatric client. Veterans Administration Centers, active and military personnel, as well as veterans who were not dishonorably discharged, may receive federally funded inpatient or outpatient care and medication for specific psychiatric and alcohol or substance use disorders. One of the greatest challenges that the veteran faces is being able to deal with the after effects or the trauma of active combat. During the Civil War times, the late effects were termed soldier's heart. After World War II, soldiers had shell shock, and then it was termed battle fatigue. Currently, mental health services are inundated by people suffering from post-traumatic stress disorder, and there's a prevalence of post-traumatic stress disorder in the general population. Among male and female soldiers 18 or older returning from Iraq, Afghanistan, and similar places, the rates range from 9% from after deployment to 3% to 31% a year after deployment. So there's a tremendous need for strong psychiatric services for that population. Forensic psychiatric care. This is for both adult and juvenile populations that have higher than average incidences of mental health or substance use disorders. So it has to do with people that are imprisoned or jailed that have mental illnesses. Treatment can be provided in the prison system itself, where the inmates are separated from the general population, or sometimes we have state hospitals that treat these forensic patients, providing psychotherapy, group counseling, medication management, and assisting with transition back to the community. Alcohol and drug use disorder. So mental health settings that were previously described may provide treatment for alcohol and substance use disorders. Specialized treatment centers exist apart from mental health systems as well. About 22, almost 23 million people over the age of 12 need treatment for some sort of illegal drug or alcohol use, and that was in 2013. Only 2.5 million actually receive treatment. The treatment is typically outpatient, includes things like counseling, education, medication management, and 12-step programs. Alcohol detoxification can be life-threatening, so inpatient care may be required for these patients. Drug rehab also provides inpatient care for detoxification of drugs, including opioids and alcohol. Self-help options: obtaining the right amount of sleep, meditating, eating right, exercising, abstaining from smoking, and limiting the use of alcohol, or some healthy responses to a variety of illnesses such as diabetes or hypertension. As with some of the other medical conditions, lifestyle choices and self-help responses often have a profound influence on quality of life and the course, progression, and the outcome of the psychiatric disorder. If we believe that the psychiatric disorder is a combination of biochemical interactions, genetics, and the environment, then it stands to reason that if we provide a healthy living situation, we are likely to have a better outcome. Example: a person that has a family history of anxiety and has demonstrated symptoms of anxiety, then a good first step or an adjunct to psychiatric treatment would be learning yoga and balance to learn how to balance the amount of life's obligations with relaxation. A voluntary network of self-help groups operates outside the formal mental health care system to provide education, contacts, and support. Since Alcoholics Anonymous was introduced in the early 20th century, self-help groups have multiplied and proven to be effective in treatment and support of these psychiatric issues. Groups specific to anxiety, depression, loss, caretakers issues, bipolar disorder, post-traumatic stress disorder, and almost every other psychiatric issue are widely available. Consumers that use mental health services and their family members have successfully united to shape the delivery of psychiatric care. And nonprofit organizations such as the National Alliance on Mental Health encourage self-help and promote the concept of recovery or self-management of mental health illness. Even though we don't have the same availability, and there's a variety of community psychiatric treatments in the U.S., a lot of patients in this country are still in need of services and they're not getting them. So we still have a lot of barriers, stigma, geographic issues, financial issues, and other factors systemically that limit access to psychiatric care in general. Mental health services are still scarce in certain areas, and a lot of American families just simply can't afford health insurance in general. So a vision for mental health in the future includes, that Americans understand mental health. That will be essential to the overall health, that mental health care is consumer and family driven, that disparities in mental health services are eliminated, that we have early mental health screening, assessment, and referral to services, and that it becomes a more common practice, that we are able to provide excellent mental health care and research to accelerate that care, and that technology is used to access mental health care and the information needed to provide successful care. So you may hear some common myths about psychiatric nurses, like that they lose their skills because they just talk all the time. Therapeutic communication is a skill that people are not born with. It's an art. They must learn it. And patients in psychiatric unit often have complex healthcare needs. And one thing you should know is they're not always able to communicate those healthcare needs. Sometimes people overlook whatever is going on with the patient because they think that it's just a behavior, or they're not just eating because they want attention, or they're not doing this because of this, and the other thing. And they totally overlook some of those very important cues when the patient is having a physical illness. And sometimes the patient doesn't have the ability to communicate that illness. So I always say, a person in a hospital, they can tell you what's going on with them. But sometimes when someone's in a developmental facility or a psychiatric facility, they're not able always to verbalize those complaints. So sometimes it does take real keen ability to focus in and pick up those subtle cues that the patient is giving you that they're actually physically ill. Now, our consumers are anybody using those mental health services and their family members. Some nonprofit organizations that try to help and encourage self-help and promote recovery, we talked about a few minutes ago, is this National Alliance of Mental Health Illnesses. And then some of these grassroots groups will help us to confront some of these stigmas, influence policies about mental health, help support the rights of those that are mentally ill, and maybe help eliminate some of those stigmas and eliminate some of those barriers to successful treatment. Some of these groups have successfully joined together, and they're now shaping the way that mental health care is delivered. The role of the psychiatric nurse on an inpatient unit would include which of the following? A. Prescribing medication. B. Maintaining a therapeutic milieu. C. Analyzing patient behavior. Or D. Providing psychotherapy. So the answer is B. Maintaining a therapeutic milieu. The therapeutic milieu is essential to successful inpatient treatment. The milieu refers to the environment in which holistic treatment occurs and includes all members of the treatment team, a positive physical setting, interactions between those who are hospitalized, and activities that promote recovery. President Barack Obama signed the Affordable Care Act in place on March 23rd in 2010. This helped millions of people who previously could not afford health care insurance to now afford it. This included millions of children and adults with mental health issues who would no longer be denied health care because of some pre-existing condition. Other provisions under the law included the insurance company's ability to deny a person's coverage because of a pre-existing condition, or rescind or take away health insurance because of a mental health related reason. It expanded coverage for young adults up to the age of 26 under their parents' policy. It provided for people over 65 through the Medicare Act, and a 50% discount for name brand drugs for those drugs that reach the Medicare donut hole. It also provided tax credits for small businesses that offer insurance. It provided affordable coverage for millions of Americans unable to afford care. It provided insurance to cover preventative services for things like depression screening and behavioral assessment for children, and it expanded integration between the primary care and behavioral health care. In addition, the Affordable Care Act and state and private insurance coverage, public assistance available for mental health care, and cost of living became available. Four assistance programs are Medicare, Medicaid, Social Security, and Veterans Administration. Medicare is a national program allowing benefits to people 65 of age or older and to any individual who is totally disabled. Medicaid operates under federal guidelines and state regulations, paying for mental health care costs for people who have extreme financial needs. The states vary widely on how they fund mental health care, but all states must provide benefits for inpatient care, primary care services, and treatments for anyone under 21. Social Security also has two programs designed to help people with disabilities. Social Security disability insurance may be provided to individuals who have worked a required length of time, paid into Social Security, and are disabled for 12 months or more. In addition, 6 out of 10 recipients of Social Security disability under the age of 65 were diagnosed with a psychiatric disorder. Supplemental Social Security income is another federal income supplement funded by general taxes that provides benefits to older adults that are blind and people with disabilities who have little or no income for basic needs such as food, clothing, and shelter. Financing psychiatric care has been complicated by the lack of parity and/or equal payment for physical as compared to psychiatric disorders. Legislation has been proposed and passed to improve mental health parity. In 1996, the Mental Health Parity Act was passed by Congress. A series of laws and commissions supporting parity followed over the next decade. This legislation required insurers to offer mental health benefits at the same level provided for medical coverage. In 2000, the Government Accountability Office found that although 86% of healthcare plans complied with the 1996 law, they also imposed limits on mental health coverage. This has since improved with the implementation of the Affordable Care Act, which banned the annual dollar limits on medical and mental health care and eliminated the lack of coverage for pre-existing conditions put into effect by the insurance companies during that time. The Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act states that if mental health or substance abuse care is covered by a private insurance plan, then these conditions must receive coverage equitable to other physical medical conditions. The 2010 Health Insurance Exchange Program requires that each state must offer mental health care and substance use services equal to other medical services. And remember, the Obama Affordable Care Act limited those annual and lifetime caps, or basically exterminated their ability to place those lifetime or annual caps. So now the law states that all states must provide inpatient care, primary care physician services, treatment for those younger than 21 years of age. Some states are fighting this, and there's still some things that are going on in the courts, in Supreme Court, for these states that are fighting against this Affordable Care Act. So this Affordable Care Act was brought by President Obama. It was signed into law March 23rd, 2010, and it stated about, the things that we just went over, but I'm going to read it again for you. So Obama signs this Affordable Care Act. This legislation helps millions of people who could not previously afford health insurance. The Affordable Care Act added millions of children and adults with mental health conditions who would no longer be denied health care because of pre-existing conditions. And this Affordable Care Act banned the annual dollar limits on medical and mental health care and eliminated the lack of coverage for pre-existing conditions that was previously put in place by insurance companies. So how do you perceive the Affordable Care Act as assisting in mental health care delivery? and try this little activity in your book by clicking on that link. So private insurance typically covers which of the following: an illness regardless of duration, an illness except mental illness, all mental illnesses over a lifetime, mental illnesses with a lifetime cap. The answer was mental illnesses with a lifetime cap. Social Security disability insurance benefits typically cover needs based on which of the following: disability, economically need, unemployment, or mental illness. And the answer here was disability. Supplemental security income benefits typically cover needs based on which of the following: mental illness, unemployment, homelessness, or economic needs. And the answer was economic needs. That concludes this recording.